Hi, good morning, everyone. We are live on 139th International CMAAO Weekly Session, 4th of March, and we have Dr. Aviral Roy joining in from Calcutta, and he's here to talk about acute mesenteric ischemia. It is a life-threatening vascular emergency disease, which he will talk about. To introduce Dr. Aviral Roy, specializes in critical care and internal medicine. This includes patients with kidney, liver, heart, lung failure, and any other acute illness, and is usually in need of life support. As a doctor in internal medicine, he treats a wide range of medical cases in adults, including outpatient, inpatient, and preventive medicine. He has previously practiced in Philadelphia in US at the Department of Critical Care. He has done numerous research and has been a co-author of multiple books and chapters, scientific papers, and articles in the area of severe sepsis, septic shocks, mechanical ventilations. He has been also in the area of experts of H1N1 pneumonia, dengue fever, HRDS, septic shocks, heart failures. So we welcome you over here for the important topic, and the platform is yours. Thank you.
Thank you, Saurabh, for that wonderful lecture, introduction. And first of all, thank you to all my fellow panelists and extremely esteemed faculty that'll be joining us. And thank you to all our viewers and listeners. It might be early in the morning or late in the evening, depending on where you're joining in from. So I thank you for giving us a moment of your time, and I really hope that I can make it worthwhile. Just gonna share my screen. Thank you. And so that's my topic today: acute mesenteric ischemia. And as Saurabh just said, I'm a consultant in critical care and internal medicine at Medica Super Specialty Hospital in Kolkata. Yeah, I have no disclosures that are relevant to this case or to this area. So, as doctors, I'm sure we have all either seen this case or we will soon see this case. It is let's see, a 65-year-old male comes to the emergency department, and he's complaining of severe abdominal pain, nausea, and vomiting. On past history, you ask, he's got some uncontrolled diabetes. He's an active smoker, maybe 1 to 2 packs of cigarettes a day. You do his physical exam in the ER, and he has abdominal distension, reduced bowel sounds. There's no guarding, there's no rigidity, but he's just complaining of continuous abdominal pain, and he's very nauseated, he's even vomiting a little bit. You get his vitals, his tachycardic, heart rate 124, respiratory rate maybe 20, little tachypneic 128 per minute. Blood pressure slightly on the softer side, but not really too bad, 104 by 68 millimeters of mercury, with normal saturation of 98% on room air. We get labs, and hopefully you're in a hospital that the labs result within 2-3 hours of you placing them. Some of them are even faster if they're stat, and some of us have point of care labs. White count comes to 18,000 or so. Hemoglobin is slightly low at 12.2. Platelets are in normal range. Chemistry shows, metabolic acidosis. Bicarb is reduced at 15. Chloride is normal at 101. Now, urea is slightly high, or BUN, depending on the area you're from. Urea or BUN is slightly elevated, and creatinine at 1.3. You get a lactic acid level. It's elevated at 8.4. And amylase and lipase, which you got because the patient's complaining of acute abdominal pain, is in normal range. So now you're really concerned. You get a bedside X-ray, non-specific bowel gas pattern, maybe a little bit of increased air overall, but very non-specific pattern. You get a bedside ultrasound because this is an ER, and it's suggestive of edematous bowel and maybe some ileus, but nothing definitive. So, as an ER doctor, they call you and you discuss it. Let's get a CT scan of the abdomen with contrast. You get that, and this is what You see, so this is basically a thrombosis of the superior mesenteric artery, or it's a thrombosis or an embolus in the superior mesenteric artery, causing what appears to be total occlusion of the artery, along with some dilation of the bowel. So what are we here to talk about? The topic, acute mesenteric ischemia. We'll talk about the definition and causes, the various types of presentations of this condition, along with the diagnosis and treatment guidelines. Okay, wait, there we go. AMI, or acute mesenteric ischemia, not to be confused with acute myocardial infarction. So for the purposes of our talk, AMI is acute mesenteric ischemia, is a group of diseases that are all characterized by disruption of the blood supply to the small intestine, which leads to ischemia and secondary inflammatory changes. There are multiple different pathophysiological processes which all have this common endpoint of bowel necrosis. And despite many years of progress and new techniques and endovascular techniques, new surgical techniques, imaging modalities, mortality is still 50 to 70%, depending on the etiology of the disease, which, and as we are discussing my panelists, this is a highly underreported and underdiagnosed disease, which is unfortunate because time is of the real essence over here. Think of acute mesenteric ischemia as a heart attack of the intestine, so or a stroke of the intestine. Both heart attack and strokes are very time sensitive events, and so is acute mesenteric ischemia. And unfortunately, due to it being underdiagnosed, it still continues to have really poor survival overall. So a quick overview of the blood supply to the gut. So you have the descending aorta over here. The first branch is the celiac trunk, and realistically, the celiac trunk mainly supplies what's called the foregut, which means basically the stomach over here, parts of the duodenum, basically the duodenum, the gallbladder here, and the liver, along with the spleen on the left side, right? There might be a little bit of common blood flow from this anastomosis over here that then communicates with the SMA, which is this vessel. Now, the SMA supplies the gut all the way from the jejunum to basically the transverse, the middle and the middle one third of the transverse colon is all supplied by, sorry, the lat, not the middle, but the second two-third, the proximal two-thirds of the transverse colon. So basically, the SMA supplies close to 70% of the entire length of the gut. Now, the SMA takes off over here, and it first has a few jejunal branches that go off in this area. But the first large branch of the SMA is the middle colic artery over here. And this is important because this is where the SMA rapidly narrows. And if you're going to throw an embolus, this is where 70% of most emboli to the SMA will actually lodge in. As you can imagine, any occlusion of the SMA at this level over here is going to lead to a large infarction of what appears to be most of the ileum, parts of the distal jejunum, along with the entire ascending colon and parts of the transverse colon. Yes, and then finally, the last vessel over here is the IMA, or the inferior mesenteric artery, which then basically supplies the what we call the hindgut, which is the rectum, the sigmoid colon, along with the descending colon, are a part of the splenic flexure. So, but there is an anastomosis available over here, which allows for collateral circulation to develop in case if you have chronic arteriosclerosis of the SMA. But moving on, this is a good idea of the blood supply to the gut. Again, a quick reminder from physiology, because it's been many years for a lot of us. So a little bit of supply comes to the mammary artery, also known as the thoracic artery. They have right and left. The celiac artery has around 800 to 1000 cc's, and you can see supplies the foregut predominantly. You have the superior mesenteric artery, which is going to be the mainstay of our talk today, which is again a majority of the blood supply to the gut, supplying the parts of the duodenum, all of the small intestine, and parts of the large intestine. And this is the arc of Riolan, which is basically the anastomosis between the inferior mesenteric artery and the superior mesenteric artery. The blood supply, as you remember, most of it goes into the superior mesenteric vein, which then goes on to join and become part of the portal vein. And any occlusion over here of the mesenteric vein, or you have portal vein thrombosis, can also lead to a phenotype of acute mesenteric ischemia. So, coming to causes, well, you can, so like we just discussed, we can have an arterial cause or you can have a venous cause. Most of the time, the arterial cause is occlusive, of which 50% of the times it will be embolic, and maybe 15 to 25. So let's call it 30% or so, 20% or so. It is a thrombotic cause. Now, what does thrombotic mean? It means that you have a development of acute blood clot. Now, these can be acute, where they're completely de novo, or something like, acute on chronic, which is kind of like, stable angina with an acute, acute event on top of it. Now, very interestingly, you have something called non-occlusive mesenteric ischemia, where the vessel may not necessarily be fully shut off or fully occluded, but you can still develop syndromes. Now, this is usually associated with low flow states. So, suppose you have a cardiac surgery or any sort of aortic surgery to clamp the aorta, severe sepsis, a hypercoagulable state associated with low flow, or maybe cardiogenic shock, or somebody having a heart attack. The low flow state can often induce a type of a transient mesenteric ischemia, which can very often cause symptoms if they last long enough. Abdominal compartment syndrome also leads to a type of mesenteric ischemia where there's so much venous congestion, not from occlusion, but just venous congestion, that the arterials or the abdominal pressure is so high where there is not enough blood pressure to get blood into the abdomen, which leads to a transient mesenteric ischemia. And of course, depending on drugs that you're taking, you can also have vasospasm, vasoconstriction. Rarely you can have a dissection of the arteries, which can also lead to a non-occlusive state or a thrombotic occlusive state. And as we just discussed, venous thrombosis can occur in about 5 to 15% of cases, depending on the case series you're looking at. And the treatment for venous thrombosis is usually very different. So, coming to the phenotypes and risk factors that we just discussed. So as you can imagine, arterial embolism causing acute mesenteric ischemia was the most common at 50% of all cases. And these are the regular risk factors that you, for example, have in even strokes, right? Atrial fibrillation, recent MI leading to cardiac thrombi. If you have mitral valve disease, if you have endocarditis, left ventricular aneurysm with intraventricular clot formation, previous history of embolic disease, any one of these, mycotic aneurysms, or any one of these can cause acute mesenteric ischemia from embolic disease. Now, you can also have thrombosis, whereas diffuse atherosclerotic disease, the same way that you have plaque formation in your heart, in your internal carotids, in the peripheral vessels, and the same way you can also have the same at the superior mesenteric artery. Now, the difference being this usually happens at the origin of the SMA right of the aorta. So we'll come to that in the future slides, looking at what are like what that causes and what the presentation usually is like. Now, as we discussed, non-occlusive mesenteric ischemia is usually from cardiac failure, low flow states, aortic clamping, multi-organ dysfunction causing, severe sepsis, septic shock, cardiogenic shock. And very often vasopressors, especially splanchnic vasoconstrictors, which can really reduce blood supply. And this usually happens in conjunction with, diffuse atherosclerotic disease, where the blood supply to the gut is not great to begin with. So, they will usually present with mesenteric ischemia. But usually, because as you can imagine, these patients are usually unwell and their ability to communicate is limited. This is the one that's often picked up very late. And finally, mesenteric venous thrombosis. So, anything that can cause portal hypertension, a hypercoagulable state, so there would be a history of DVT, PE, any use of oral contraceptives, any history of smoking, any active estrogen use, if the patient has any known thrombophilia, genetic disorders, protein C, protein S, factor 5 laden, and very interestingly, pancreatitis, because when they get pancreatitis, they can very often, cause a thrombosis of the splenic vein, which can then progress and occlude the portal vein, and as the clot progresses, it can cause a superior mesenteric vein thrombosis. I've added a small QR code in order to see if you would like to take a look at that paper. So what are the clinical presentations that acute mesenteric ischemia would normally come on as? So the classical presentation, right? Acute onset of severe abdominal pain, nausea, vomiting, and diarrhea. This is what is we associate with acute mesenteric ischemia. This was taught to us in medical school, and this is where it happens in acute emboli. Now, if you have gut infarction, which is advanced ischemia, then very often you can have bloody diarrhea. As we discussed, the most common site of the emboli getting stuck is just distal to the middle colic artery or just proximal to the middle colic artery, depending on your exact anatomy. You will often spare the proximal jejunum, but you'll basically infarct most of your small gut. Most common origin is is intracardiac, so whether that be a clot from atrial fibrillation or endocarditis or intraventricular thrombosis or intraventricular clots. And as you can see, survival is about 30 to 50% depending on when the patient presents and comorbidities. So thrombotic disease, and this is most commonly seen at the origin of the SMA. So think of it like an osteal disease, right? Just distal to the origin of the SMA is the most common site. And these patients have like an acute on chronic syndrome. I'm sure when you were young, most of us, despite our mothers and fathers not telling us not to do it, would go and play right after eating, and you get that, you get that stomach pain. Think of it like that, right? These people, every time they have food, they'll have pain, nausea, vomiting, which basically like chronic renal insufficiency. They have poor to gain weight. They're usually malnourished just because every time they eat food or take a large meal, they just have severe abdominal pain. So they either avoid food or they just have small meals. The trouble with this is because they're used to stomach pain or abdominal pain rather, they usually seek care much later as opposed to other gut pain because they're like, this is just a regular day for them. And this is what's really concerning because as you can see, just if the clot happens or the thrombosis happens at the origin of the SMA, you're going to lose the entire midgut, which means you're going to lose the entire jejunum onwards all the way to the transverse colon. And that is something that is not survivable. Usually, this is atherosclerotic disease and has very similar risk factors as peripheral vascular disease or, coronary disease, stroke, etc. And because the loss of gut is so extensive, survival over here is between 10 to 30%. So the non-occlusive mesenteric ischemia, usually seen in the elderly, critically ill population, you know, they usually have severe mesenteric atherosclerosis, and then they'll have an acute insult on top of that. Suppose if they had a heart attack, they're in cardiogenic shock, they have heart failure, or maybe they had to undergo some sort of aortic surgery, or these patients in the ICU with a severe infection, hypotensive on vasopressors. They might be intubated and sedated on the ventilator. The infection is getting better, but they're not improving. Their lactate is constantly rising, and not sure what's going on. They are often on adrenergic vasopressors, so they will be on depending on norepinephrine or noradrenaline depending on the country that you are in. And occasionally there are patients who have undergone aortic surgery. For us as doctors, these patients who should be recovering from their initial insult or whatever is the cause of the initial deterioration in their health, once that is fixed, if they fail to recover or they do not recover fast enough or there's something else going on, then one of the things that we should consider is non-occlusive mesenteric ischemia. And the fourth type of presentation we discussed Mesenteric venous thrombosis, 5-15% of cases. They'll present with, very non-specific abdominal pain, usually the lower quadrants bilaterally. It may have some association with postprandial, with food postprandial. Some of them might have hemoccult stool positive because it's low-grade ischemia with some sort of, ischemic colitis going on. But the trouble is, as the ischemia worsens, they start to develop ascites. They have bloody ascites. They'll have a little bit of, bloody stool. They thought third spacing in the abdomen, and they're losing more and more volume, plasma in the abdomen, which actually makes their blood more and more hypercoagulable, more and more hemoconcentrated, and which actually worsens the underlying ischemia. Every case of mesenteric venous thrombosis, you would have to do a full hypercoagulability workup, the same way you do for, a PE or a DVT or recurrent PE or DVT, because very often they are associated hypercoagulable disease conditions. So, what's your eureka moment when you are diagnosing, AMI? So, as we saw in our case early on, we got an abdominal X-ray. Really a very, very limited utility. It's not going to be able to tell you anything unless you have a perforated abdomen or a perforated gut. Sorry, a perforated gut, in which case, that's an emergency in any case. So it's not really the investigation of choice for acute mesenteric ischemia. Elevated lactate and elevated LDH are very, very sensitive indicators, but as you can imagine, they're not specific. There's so many conditions that got the elevated lactate and LDH. So, and in fact, there are no specific lab values, not even amylase and lipase. There are specific indicators of bowel ischemia, and very often, but unexplained elevated lactate in a patient with abdominal pain should really, really get your, perk up your ears as there's something weird going on in that gut. So, unexplained lactate, one of the things that you should rule out in somebody who's hemodynamically stable is gut ischemia. White count of more than 15,000 is seen in over 90% of patients. CT angiogram is actually the current gold standard because it has a diagnostic sensitivity of 93% and a specificity of over 100, of not over exactly 100%. So abdominal pain, symptoms out of proportion, multiple risk factors, go ahead, get a CT angio. And abdominal pain out of proportional to clinical findings has to be assumed as acute mesenteric ischemia unless proven otherwise. And these are the current guidelines of the World Society of Emergency Surgery. So, what are my treatment options? And basically, these are all my treatment options. Over here, it looks like water. It's actually fluids, right? Fluid resuscitation is very, very important. Antibiotics. If they have, we'll come to the next few slides. But surgery is a part of the management. Endovascular management is essential. From heparin, giving some sort of anticoagulation, whether it be heparin or low molecular weight heparin, and of course, discussion with patient family about what they, advanced directives are, whether they would want aggressive care. Because remember, even if you do get control, this is usually a condition requires multiple surgeries or multiple surgeries or multiple interventions. So it can be pretty invasive for a patient who's already chronically ill. So once a diagnosis of acute mesenteric ischemia is made, fluid resuscitation should commence immediately to enhance visceral perfusion. Electrolyte abnormality should be corrected, and you start with nasogastric decompression. Broad spectrum antibiotics should be administered immediately unless contraindicated, and you should anticoagulate with IV heparin. So the question is, why broad spectrum antibiotics, especially because, well, this is not a septic condition. You are correct, but the largest amount, the biggest component of our gut are our gut bacteria. And with the loss of blood supply to the gut, the first thing that's going to happen is they're going to start to translocate and cause peritonitis and ischemia and infection, which any signs of overt peritonitis, any abdominal guarding, rigidity, tenderness, you have to go forward for a prompt laparotomy. Assume that the bowel is completely ischemic or in fact already perforated. Now, while you're doing the prompt laparotomy, one of the things that you could consider is a surgical embolectomy / thrombectomy. However, if you catch the patient early and they're not completely, the bowel is still viable, very often some people will do a quick look of an endovascular embolectomy or a thrombectomy. If your diagnosis is non-occlusive mesenteric ischemia, the focus is not actually the gut, but to correct the underlying condition that is leading to the acute non-occlusive mesenteric ischemia. But if you do have infarcted gut, you will have to resect it promptly. Otherwise, it's just going to complicate the course of your condition even further. Like we said, the SMA supplies the entire midgut, which is around 70% of the length of our gut. So if you have massive gut necrosis with extensive, bowel resection, you are going to have to talk to family members, especially with their comorbidities, what their advanced directives are, because these are patients very often who might be left with short gut syndrome or, not even with enough gut to be compatible with life. They'll be completely dependent on PN. At which point, well, if they're young, you could consider intestinal transplant, which is a relatively new surgery, but not very commonly done. But most often, talk to family members, talk to the patient, and get advanced directives before future planning. If you have partial occlusion of the artery, as we discussed, you can have endovascular revascularization. Very often you need damage control surgery with planned re-laparotomy after initial resection, because even though you might have areas of questionable gut that you may have left in, they can very often infarct later on. So it's not just one surgery. Very often you would need to go in and do recurrent surgeries. If the patients have sepsis, of which a lot of them will present it, especially if they've perforated their gut, they very often will have refractory sepsis, and you may need to leave the bowel, the abdomen open, and do repeat relooks and repeat abdominal washouts. Mesenteric venous thrombosis commonly can be treated with a continuous infusion of IV or unfractionated heparin, and this is the initial treatment of choice that is currently recommended. And finally, so you're in a smaller hospital, and you have to talk to the family members and give them a prognosis on what the outcomes are going to be. And this is a study which actually gives us predictive factors for intestinal necrosis. So they looked at 3 risk factors. One was presence of any organ failure, presence of elevated serum lactate of more than 2 over here, and bowel loop dilation on CT scan. And if you had 0 risk factors, your rate of ITIN, which is ischemic transmural intestinal necrosis, if you have 0 risk factors, it's basically 3%. And anything with more than 2 risk factors, you're looking at more than around 90% of transmural intestinal necrosis. And it's not that difficult to get 2 risk factors. Like we said, our patient in the very beginning had elevated lactic acid, and he had bowel loop dilation on CT scan. He had no organ failure. And those 2 risk factors already showed that the risk of having transmural necrosis, example, was already 90%. So this is a patient that would have needed surgery. There's a 90% chance he would have needed surgery for resection of infarcted gut. And with that, thank you so much. And back to you to our esteemed panel.
Thank you, Dr. Aviral. We will now open the floor for the question answers. I welcome Dr. Chong for taking up the question answer session with us. Thank you. Dr. Chong.
Thank you, Dr. Avira. Wonderful presentation. Good. It's something if you don't think about it, you might not diagnose it. So that's the problem. I think you always got to keep this sort of diagnosis at the back of your mind. Rare they may be, but yeah, if you certainly are not looking for it, you will never find it.
Exactly right. And you very often, if you don't catch his diagnosis in the emergency room itself, by the time they come up to the to the ICU, it's very often too late to make the diagnosis in the ICU. So this is a diagnosis that usually has to be made either in the OPD world, in the doctor's chambers, or in the emergency department itself. The ICU is really the place to make the non-occlusive mesenteric ischemia diagnosis, but otherwise, it's really ER and outpatient physician diagnosis.
Yeah, very, very tough to make such diagnosis. I mean, it's not easy at all. Even thinking about it is already a big thing,
It's very non-specific, right? Especially in a country like ours, in the tropical world, everybody has abdominal pain, nausea, vomiting, and the average question is, where did you eat?
Yeah.
What have you been eating? So, that really muddies our waters a little bit.
Yeah. Index of suspicion has to be there. Index of suspicion. And if you don't have it, it's wow. It's quite a leap to make the diagnosis, quite a leap.
And the trouble is, if you miss it, it's absolutely devastating. Like there's like a 30% survival chance if you miss a diag, or 50% depending upon, that's ARDS. That's like severe ARDS or septic shock type of survival pictures. Septic shock patients have a higher chance of surviving that acute mesenteric ischemia. So, it's a devastating diagnosis to miss.
Yeah. So I put this diagnosis together with things like aortic dissection, Stringomyelia. This whole group, wow, very, very challenging to diagnose, to even be thinking about it. I mean, it's like so tough. Therein lies the difficulty. There it actually lies the difficulty, and you need a lot of experience to even be thinking about this sort of condition. It's not easy. So, if, for example, you do a CT scan but you didn't do the contrast, hey,
useless.
you miss it.
You'll see some distended bowel, and then they'd be like, get contrast to confirm, and then you've lost like 4 hours already.
Yeah. So if you just do a CT scan and you don't do the contrast, you're also stuck.
Yeah.
And labs take a while to come back, and then the index of suspicion, and then high total white, you think about infection.
You're right. So luckily, a lot of point of care ABGs have really started to come out well. They give you the quick electrolytes along with the lactic acid. And, you can get that within 30 minutes of them turning up to the ice of the ER. And so if you have unexplained high lactic acid with abdominal pain and, anion gap metabolic acidosis, one of the things you really have, of course, sepsis is the number one diagnosis you'd be looking to make. But, one of the things you have to think about mesenteric ischemia, especially on abdominal pain. Now, the good thing with sepsis is that the first two things of treatment are the same. You give them fluids, you give them antibiotics, right? So luckily the treatment is that there's that common pathway there. But then that's where really you need a high index of suspicion to make that diagnosis of acute mesenteric ischemia versus intra-abdominal sepsis.
Yeah, so tough. Such a tough diagnosis to make. Such a tough and yeah. Do we have any questions from the floor? Yes, Monica.
Great presentation, Dr. Roy. Again, it was a great summary, and it was a capsule summary, and I love the clinical case that you started, and you used the units I'm familiar with, so that was really nice. With the one question I would have is, what would you recommend for those who are at high risk for developing acute mesenteric ischemia in terms of preventing this? What would be the things that you would counsel those who you would identify to make sure it doesn't happen, besides stop smoking?
Wow, you took away my number one answer, right? So I guess I would talk to them the same way I would talk to any patient, who has heart disease, stroke, peripheral vascular disease, because the risk factors are all the same. It'd be like, give up smoking, you really need to get your diabetes and under control. You need to get your blood pressure under control. Frequent visits. I might refer them to, especially if they have something like mesenteric angina, where they have narrowing of the SMA. I might refer them to interventional radiologists, depending on the country. Some countries have them, some don't. Where they might, whether they're even a candidate for mesenteric artery stenting or balloon dilation or along those lines. But that is more treatment than prevention. Prevention is again, good. Well, what's happened has happened. So, trying to prevent further damage, and if they are looking for Afib or making sure they have no hypercoagulable state, trying to get the risk factors down, avoid dehydration, drink lots of water, stuff like that.
Perfect. Thank you.
Is there a clinical, can you tell us a bit more about the clinical presentation of mesenteric angina? Whether there are any clinical points that we can pick up in your experience that when you see this mesenteric angina?
So typically what the patient would present as, or, would present to, this is more of an outpatient world. They'd come to their regular doctor or maybe to a gastroenterologist and say, you know what, I can't eat food. Every time I have food, I have abdominal pain. I feel nauseated. I feel like vomiting. I'm having abdominal pain. And, I've been really losing. They're very often very lean, and they will give a history of weight loss. Now, the first thing that I guarantee you, anybody in my part of the country or my part of the world would think about is this person's got gas or, severe peptic ulcer disease or, gastritis, and start them on PPIs. And, of course, they don't respond to PPI because, you give them that and it makes no difference. So then you need to look at the risk factors: hypertensive, heart disease, history of stroke. So it's again something that you need to put together. But usually, yes, it's mesenteric angina is getting abdominal pain after any sort of caloric intake.
Thank you.
Hello.
Yes, Afib.
Yes, thank you very much for your excellent lecture. But unfortunately, I have been partially away just now because of some clinical engagement, some patient in front of me. So, in fact, if I forget not Morris Gibb, the brother in BGs, had also got something like mesenteric ischemia, and unfortunately, I'm not sure whether eventually he died from it, but I have a personal experience of a patient with mesenteric ischemia. I'm a pediatrician, so the boy was 5 years old when he first complained of abdominal pain. And at first, the abdominal pain was only not so severe and comes and goes. But then one day he suddenly had a severe abdominal pain, and then he was admitted into the hospital, and we eventually had done the CT scan of the abdomen and found that there was a volvulus of the intestine, and then there was mesenteric ischemia. And unfortunately, the child already had some signs of ischemia, and the surgeon was afraid that there would be gangrene. And so he had opened the abdomen and thinking of making the volvulus going back to, rewind the intestine. But then eventually he had failed to do so, he said, and then he cut off, I think, 10 inches of the small intestine. So my question is, how can we prevent the cause of this disease when the child had abdominal pain? So it's sometimes not so easy to convince the parents to do a CT scan abdomen, with contrast. So perhaps if we could do it earlier and found a volvulus already, and then perhaps we could prevent the outcome that the surgeon said is such a dangerous ischemic gangrene of the intestine, and then they had to resect the part of the intestine. I don't know whether volvulus of the intestines of such a child or in adults could be reverted by surgery earlier. I just wonder if you have such experience. Thank you.
Thank you, Dr. Alvin. So one of the I won't say good things, but the better thing with the volvulus is the presentation is where they'll have they'll have nausea, vomiting, but they'll have signs of ileus, or they'll have signs of acute abdominal, subacute or acute abdominal intestinal obstruction. And this is very easily seen on X-ray. An abdominal X-ray is an excellent investigation in such a chance, especially if the sigmoid volvulus, where you get the classical, the bent tire sign or the rubber tire sign or something like that, right? You can easily see it on a regular abdominal X-ray. So the good thing with the volvulus is that, but yes, a volvulus, if it ties off its blood supply, then you can get all the X-rays you want. You still need to open them up and undo the volvulus, and hopefully before ischemia and gut infarction sets in.
So thank you. The X-ray is very, very valuable and accessible.
Yes.
Yeah. So is it uprights, lateral X-ray, or
just flat
organ
and upright, just because you want to make sure there's no intra-abdominal air. So a flat and upright. Of course, CT scan would be significantly superior to an abdominal X-ray, but the good thing is at least a volvulus will show up on an abdominal X-ray. The acute mesenteric ischemia doesn't even show up on the X-ray.
Thank you.
Excellent presentation, sir. And
thank you, Dr. Chaudhary.
As you said, higher index of suspicion in a patient with less abdominal signs. As Dr. Ellen Chan was telling, a picture of obstruction would be more easily available clinically when the abdomen is distended and the patient is vomiting and those types of features. Here, during ischemia, the pain would be more till the gangrene is setting. Pain might reduce with setting up of the gangrene.
Correct.
Very nice, sir.
Thank you, Dr. Chaudhary. Thank you. So one important thing is, as Dr. Chaudhary did point out, sorry, go ahead, sorry.
No, go ahead. I was asking if there is any more questions on the floor. Go ahead. Go ahead, Dr.
I was just saying, so what happens is, just referring to what Dr. Chaudhary said, is that as it progresses and once overt peritonitis sets in, then of course your signs and symptoms are equal, right? You have abdominal pain along with significant guarding, rigidity, tenderness. The other thing is as the pain has been going on and for some time, you kind of get accustomed to the pain a little bit. So maybe the intensity of the pain might start to wean off. So maybe the pain may not be so bad, especially if it's been going on for some time. Or if it is somebody who's presenting with the acute on chronic presentation and acute thrombosis on a chronic mesenteric angina or mesenteric ischemia, where then they may not present initially with as much pain, or the pain may not be as bad because they're always used to a certain threshold level of pain. So they may not be coming there, oh, it's a 10 out of 10 pain. They're like, I usually have a 3 on 10 pain. Today it's a 6 on 10 or a 7 on 10. And that is where you really need to have a really low index of suspicion in diagnosing this.
Fair enough, sir.
Hi, Dr. Arvind. Can you share your experience with the COVID-19 patient with mesenteric ischemia? Did you found many cases or you haven't seen anything? Thank you.
Wonderful question, sir. Thank you so much. Honestly speaking, we didn't see a lot of case of mesenteric ischemia directly in our COVID population. I think we had one case of SMV thrombosis. But that patient was and we just started the patient on low molecular weight heparin and they did okay. I think that was the only case that we saw in our institution, but no acute mesenteric thrombosis or acute arterial mesenteric ischemia. We have seen a lot of cases. In the ICU of the NOMI where they're just not recovering. You get their hemodynamics set up, and despite that, their lactate is going up. So we usually get a triphasic CT of the abdomen, and that usually is what shows, evidence of colitis or, fat stranding around the abdomen. So, and then we go ahead and get called gastroenterology to come and take a look at that point. And then that's when they usually diagnose some level of, ischemic colitis. Now, in my center over here, while we do have endovascular options, most of my ICU patients are too sick to go into the cath lab. There are multiple pressors, so it's just you have to treat the underlying condition and try to optimize as much as possible.
Thank you so much. Thank you.
Do you have any other questions on the floor?
One last question. May I just ask, do you see the role of atrial fibrillation? I mean, do you see a lot of AF patients with this sort of presentation or relationship with mesenteric thrombosis?
So yeah, we do see a few of the few cases that we have caught early on. The trouble is most of these cases come as abdominal pain, and then they come to the ER, and then they were usually taken up by our gastroenterology team. But yes, when they do come to the ICU, one of the usual core risk factors that almost 75% of them had was either newly diagnosed atrial fibrillation or atrial fibrillation, and they were not compliant to their medications. So as we all know, your CHADS VAS score predicts stroke, but actually it predicts, embolization, right? It's an embolization risk. So yes, it's the same risk factor for stroke. You're running the same risk of, sending one to your gut, sending one to your renal arteries or anywhere, or, to your peripheral arteries, sorry. So of the few cases we have seen, yes, we have usually diagnosed them, newly diagnosed AFib or poorly controlled, or AFib with poorly controlled their prophylactic anticoagulation.
Yeah, thank you. I mean, sometimes you get AFib patients with abdominal pain and you're thinking to yourself.
After my first two cases, I'm like, no, not again.
Yeah, but it's thank you.
Yeah.
Okay, so I believe this concludes the question answers, and we would look forward for more sessions and more interesting knowledge coming from Dr. Aviral in the future sessions. With this note, we would like to end this session today, and we would come again with more doctors, more knowledge, more sessions. Thank you so much for joining in. Thank you, Dr. Aviral. Do you have any take-home message for anyone over here, for the general public also, since there are non-doctors also watching this forum?
Definitely, I guess the take-home message is, first of all, take care of your health. Preventive health is essential. So, ensure that you're taking all your vaccines, all your boosters whenever you're due for them. Make sure you're visiting your doctor, especially if you're over the age of 40, at least once a year. Get your preventive health checkups done, and ensure if you do have any risk factors or any diabetes, hypertension, try to get them under as good control as you can. And that's for the general public, because there's not really much more that you can do apart from take care of yourself. If you can get a yearly maintenance for your car, why not for yourself? For us general practitioners and people in the general practice world, and again, patient compliance, patient education, and as far as AMI is concerned, abdominal pain with nausea, vomiting with no significant signs, somebody with high risk features, of course, now if they have classical symptoms, they can be whatever, but if you have this constellation, keep AMI at pretty high up on your list of differential diagnosis. It's not very common, but if you miss it, your patients there's a very, very high risk of morbidity and mortality. So as a doctor, that's number one thing, like reduce our morbid. So keep it high up. You may not see it very often, but you'll really feel really bad if you miss it. And that's it.
Well, with much further ado, thank you very much, Dr. Aviral. Most interesting presentation and discussion thereafter. A lot of clinical points, a lot of difficult areas of difficulty that we've discussed, especially with diagnosis and so on, and even with treatment. So thank you very much. Without much further ado, thank you all for joining, and look forward to seeing all of you soon, next week or the week after, for another session of this get together for CMAAO. Thank you.